Hi there, good afternoon everyone. So we're here to talk to you about the Lincolnshire Living with Cancer dashboard. And the title of our talk is Transforming Words and Feelings to Numbers and Statistics. So I'm Kathie McPeake, I'm Macmillan Living with Cancer Programme Manager for Lincolnshire, and this is my colleague.
I'm Kelly Dixon, I'm the Senior Cancer Data Analyst for Lincolnshire Region.
So I think it'd be useful to give some context to the Living with Cancer dashboard. So the impact of a cancer diagnosis can affect people way beyond their physical health. So their mental health, their financial health, their work, their relationships, their sexual health, their spiritual health can all be impacted. And evidence shows that good holistic support offered to people with a cancer diagnosis, well, before, during and after a cancer diagnosis, often has better outcomes than for people who don't get offered this kind of support. There are approximately 37,500 people living with cancer in Lincolnshire, and this is predicted to rise to over 45,000 by 2030. So in response to this, the Living with Cancer programme was established in 2016 and was funded by Macmillan Cancer Support. In 2019, the long-term plan was published, and this placed greater emphasis on implementing personalised care and support for people living with cancer, responding to national cancer patient experience and quality of life surveys, and also addressing health inequalities. Our approach in Lincolnshire, our strategic priorities and our objectives have mostly been set using qualitative data, so that is large programmes of stakeholder and patient and public engagement and involvement. So this is your words and your feelings. Our approach synthesises 5 evidence ways of working. Put simply, we are creating a better and sustainable future for supporting people living with cancer, involving and integrating all relevant parts of the health and social care system, using the assets we already have, supporting people in the place that they would like and in the way that they would like, and placing people at the centre of everything that we do. In 2022, we were lucky enough to secure recurrent funding from Lincolnshire Integrated Care Board for 7 full-time posts and 1 post in our acute trust. It was at this point that I was told in no uncertain terms that we had to demonstrate our impact and also our return on investment. And it was also at this point that I had an absolutely massive panic, because I don't really do data. And I said, I haven't got any data, and I stamped my foot. And it was at that point that thankfully I brought Kelly in.
Yeah, so when she said she has that panic attack, she really did have a panic attack. So we sat down and we said, well, where is your data? And she says, well, I have patient stories. I can give you patient experience, I can give you patient stories, but we don't have data. So we searched and found the data. There, all of it. It's everywhere. It's from your national cancer data sets. It's got your Cancer Research UK, your Macmillans, your local kidney coffee shop support group. There's lots of data out there. What the biggest challenge was actually getting it and collating it into some kind of usable format. So we started collating bits that we could get to, accessing data and bringing it into this one source. And it's the top left is our dashboard, and it contains a huge amount of data. But I'm not going to cover it in this session because it will take hours. But this is kind of what it looks like. There's lots of information in this dashboard, and there's huge amounts of information in it. The eagle-eyed among you will actually recognise it's in Excel. And it's been built very deliberately in Excel because we wanted to share it across multiple organisations. We wanted it to be accessible by everyone. So we didn't want things like software restrictions or licenses. So it's all been built in Power Query. and then it has an Excel front end. But we also have it in Power BI as well, just for things like geographical mapping and certain things that Excel don't do very well. So there was no point me having the data. What we did was we set up all these drill downs so people could go in and analyse their own data. So you could filter by tumour site, by number of contacts, what nurse they had. We can also have a look at their holistic needs data. What bothers patients? So we can see that emotional and psychological support was a huge issue for Lincolnshire. And Kathie's team set up psychological programmes to help that. What we tried to do was build this loop. So I've heard several times today that data should tell that story. What we've tried to do is get the stories to drive the numbers to drive the stories, and create that feedback loop. And one of the ways we've started to do it is here. So this section here, what you can see here is that we've got a case study. So it was a patient that went through our system and an intervention was made with them. And I'm going to use case study 2 for those that can see it, because case study 1 was a really complicated patient. But for case study 2, this patient had an intervention by our coordinators. And what it meant was that patient avoided 2 A&E attendances. And if they'd had those A&E attendances, it's likely they would have been admitted and had bed stays. So we can start to put a cost to that acute avoidance. What we also started to do was to look at the social value aspects. So case study 2 would not have attended their cancer surgery without that intervention. If they had not had that surgery, the clinician says that that patient would not have survived. So what we did was we re-engaged that patient with the system. We got trust back in GPs, and the patient survived. So we're looking at those further social value engine measures and how we engage with that. So I'm going to hand over to Kathie to tell you what we're doing with it.
So I guess this is really a before and after. So I'll give you some examples of the impact on our team that Kelly's dashboard has had. So before, we made decisions on health and wellbeing projects using anecdotal evidence and honestly sometimes on instinct, just what we heard from people, what patients have told us. So we knew, for instance, that patients' mental health was an issue. But now we can use HNA data and distress scores to define and design projects. So, for instance, our level 4 psycho-oncology project, we've been able to increase the number of whole-time equivalent clinical psychologists in Lincolnshire from 0.6 whole-time equivalents to 3.2 whole-time equivalents. And also our financial support project, we knew that cancer patients in Lincolnshire were really struggling with the cost of living crisis. So we've been able to use the data from holistic needs assessments to set up financial support, including an amazing collaborative project that we're doing with Anglian Water. So the future of the dashboard. So there is sustainability of approach. We've done this within Lincolnshire ICB. We've had no external funding for this whatsoever. So we will be able to continue to develop it. We have the opportunity to enrich the measurements of qualitative data with additional values using the social value engine, we think, and potentially other tools as well. We have the opportunity to develop a system-wide consistent approach for analysing qualitative data that can be used by other long-term condition programmes. And we've got the opportunity to scale up and spread locally for other long-term conditions and nationally for living with cancer and long-term condition programmes. We've been working with East Midlands Cancer Alliance, NHS England, and today I had an email from Movember, who is the prostate cancer charity, who are wanting to have a look at our dashboard as well. And finally, we have the opportunity for publication. I'm very keen on publication in peer-reviewed journals, but I'll do the words. Kelly will do the numbers. So that's the end. This is our team. Lovely. We're not that orange, honestly. I don't quite know what happened to that photo, but and we were shortlisted for an HSJ award this year as well. So thank you.
Fantastic. Thank you very much. Okay, we have 5 minutes for some questions, and a few have come through on Slido. Someone anonymous asks, did you consider using something open source and free like Python rather than Excel?
Yeah, probably. We could have used something, but it was the availability of data and the accessibility. We didn't want something that would be huge to maintain. We wanted something that multiple people could just pick up and understand how to use. Now, in Lincolnshire, we don't have a massive technical expertise. So picking up an Excel file and doing a few Excel formulas is certainly more in the scheme of what people can cope with. So we decided to keep it very, very simple with the possibility of expanding it further as it develops and as there's need for it.
Okay, thank you very much. Could you possibly talk a little bit more about the types of analysis you did on your qualitative information and patient experience?
Oh, types of analysis. So anything and anything that we could literally think of, we push through the system. So the dashboard is more about self-reporting. So it's about you drilling into a cohort that you are interested in and actually seeing the results in that. But the analysis that we've done is all sorts. So we've done the health inequalities, we've done geographical mapping. We've also looked at what matters to our patients. So, for example, the psychological support. If patients are really struggling mentally, that has a huge impact. So then we take those findings, pass them to Kathie's team, and they come up with some wonderful solution to actually help the patients for that. So there isn't much that we haven't looked at for Lincolnshire patients, I think.
Okay, thank you very much. Okay, next up, Nicola asks, how did you get the figures for case study 2? For example, how did you know that 2 A&E visits were avoided?
So when we started looking at it, so the case studies are reviewed by a peer panel to start with. And what we've done is we've put different people on that panel. So there's a clinical aspect to it, there's a GP, a nurse, a data person and a project manager. So by having the different people from different backgrounds, we get different results from that case study. So I might look at it as a data analyst and say, actually, that's caused something over here. But a GP might look at it and see something completely different. So what we've done is over that a period of doing quite a number of case studies is we've filtered that down to actually this is what we want to count and this is how we're going to count them. So those panels still happen and we still go through case studies in detail and still revise those.
Okay, thank you. Divya asks, have you investigated the reasons for A&E attendance avoidance? Is there potential for patterns of cross-behaviour associated with subpopulations who might be avoiding A&E attendance?
We haven't really looked at A&E avoidance. So the numbers on the case studies are avoidance to the system. So maybe instead of the patient going to A&E, we've had a GP come out and administer the treatment at home. So it's an avoidance to, it's a cost avoidance to our acute system. What we're looking at is developing that much wider and further. So we know that actually there may be an acute avoidance system, but there may be a cost in primary care or community. We also know that if we have people living longer, which is the aim, that ultimately down the line they are going to cost more. So it is very, very early days, but we are quite excited as to how it could develop going forward.
Okay, thank you. We've got a couple more questions on Slido, but as is the way, I will just pause and see if there's any questions in the room for people who haven't accessed Slido. Anybody want to put their hand up? If not, I will return to the two final questions. So Phil asks, easy ID of patients who are living with cancer is notoriously difficult. Can you measure a baseline of how many people are living with cancer, or does inclusion on the products rely on a patient accessing a service somewhere to be included or counted?
So we are from Lincolnshire, and actually we do have quite a unique data set up for Lincolnshire. We do have a GP joined up data set in Lincolnshire that we have access to. And I have quite a unique role in that although I'm employed by the ICB, I do actually have contracts within all our providers. So I can go in and get direct patient level data. Match that to our GP joined up data set makes our data quite rich. A lot of regions aren't quite at that point. But they're a lot further along in some things like machine learning and stuff, which we're not.
Not yet. And then finally, Johnny asks, with so many data sets that you use, did you need to link patients between the data sets? And if so, was this straightforward?
Yeah, predominantly because we do have patient level data. We can also run that through things like Descro and use the joined up data sets. So we do have very, very rich data. We do have two versions of the dashboard. One which is public and completely anonymised, that is group data only. And then there's a ULHT version which is used by the nurses to identify specific cohorts of patients. And that is does have patient level data in it.
Okay, thank you very much. So that's the end of the session in this room. But please now do make your way to the final closing talk in the auditorium at 5:10. So let's just thank wonderful talk again.